Hi, my name is Lilybeth Penafuerte, and I'm a registered dietitian. The objective of this presentation is to evaluate natural therapies for age-related macular degeneration, which is an eye disease that affects the lives of many people worldwide. Some of the leading causes of blindness and low vision in the United States are primarily age-related eye diseases such as age-related macular degeneration, cataract, diabetic retinopathy, and glaucoma. Research has estimated that 61 million adults in the United States are at increased risk for serious vision loss, but unfortunately, only half visited an eye doctor in the past 12 months. The CDC reported that blindness or vision problems account for the top 10 disabilities among adults aged 18 years and older. Vision loss has serious consequences for the individual as well as those who care for and about people who have compromised vision because it impedes the ability to read, drive, prepare meals, watch television, and attend to personal affairs. 5.5 million people are projected to be blind or have low vision by 2020, and this number is expected to increase twofold by 2050. Non-Hispanic white individuals are at increased risk for vision impairment compared to other racial ethnic groups for both men and women. Eye diseases are often asymptomatic in the early treatable stages. The prevalence of blindness and vision impairment increases rapidly with age among all racial and ethnic groups, especially after age 75. Smoking and ultraviolet light exposure are other risk factors in the development of eye diseases affecting older Americans. The annual economic impact of major vision problems among the adult population 40 years and older is more than $145 billion. The National Eye Institute of the National Institutes of Health projected that by 2050, without effective interventions, diabetic retinopathy will increase 72%, cataract will increase 87%, glaucoma will increase 100%, age-related macular degeneration will increase 100%, vision impairment and blindness will increase 150%, and the annual cost of vision problems will increase by 157% to $373 billion. Age-related macular degeneration, or AMD, is a condition of the central area or macula of the back of the eye known as the retina. The macula degenerates with age. Sometimes this deterioration happens more quickly and is associated with a particular appearance at the back of the eye. In its earliest stage, known as early or dry AMD, yellow spots called drusen can be seen under the retina by an eye health professional while examining the eye. As AMD progresses, it can lead to the loss of the cells in the back of the eye, which are needed for vision. Sometimes new and harmful blood vessels grow in the macula. These new blood vessels may bleed and cause scarring, which is a characteristic of late or wet AMD. AMD is diagnosed with a comprehensive dilated eye exam. There's currently no treatment for early AMD, but eating healthy, engaging in regular exercise, and quitting smoking can help. However, dietary supplements including vitamins and minerals, injections, and laser treatment are used for the treatment of intermediate or late AMD. AMD can be very serious. AMD is a leading cause of vision loss in Americans 60 years of age and older, as well as a leading cause of irreversible blindness and visual impairment in the world. AMD is an irreversible destruction of the macula, which leads to the loss of the sharp, fine detail, straight-ahead vision required for activities like reading, driving, recognizing faces, and seeing the world in color. 11 million people have a form of AMD, which is expected to double to 22 million by 2050, while 196 million people are expected to have AMD worldwide by 2020, and projected to increase to 288 million by 2040. The estimated global cost of AMD is $343 billion, with $255 billion in direct healthcare costs. Some of the risk factors for AMD include older age, race, predominantly non-Hispanic whites, family history of AMD, farsightedness, light-colored eyes, cardiovascular disease, smoking, and hypertension. Here is a visual produced by the National Eye Institute that illustrates the projection of AMD to 5.4 million people based on a total of 80 million people and the number of Americans who will be 65 and older in 2050. In the very center of the retina is the macula, which contains the highest concentration of light-sensitive cells, called cones. Cones provide sharp, detailed central vision used in activities like driving and reading. In AMD, cells in the macular region begin to die, causing blind spots and distorted central vision. The two types of macular degeneration are dry and wet. People can develop both types of the disease, and the disease can affect one or both eyes and may progress slowly or rapidly. Dry macular degeneration may advance and cause vision loss with or without turning into the wet type of the disease. However, not everyone with early AMD will develop the advanced form of the disease. AMD results from a partial breakdown of the insulating layer between the retina and the choroid layer of blood vessels behind the retina. Macular degeneration results in the loss of central vision only. The hallmark of early AMD is the formation of drusen, pigmentary changes at the macula, and mild to moderate vision loss. Oxidative stress has a major role in the development and progression of AMD. The retina and retinal pigment epithelium, or RPE, are susceptible to oxidative stress damage because they have high metabolic demands and require ample ATP to support their functions. Reactive oxygen species like hydrogen peroxide, superoxide anions, hydroxyl free radicals, and hydroperoxyl radicals are created as a byproduct of increased oxidative phosphorylation in the mitochondria. Constant exposure of both the retina and RPE to UV radiation from white bright light impacts ocular chromophores and induces DNA damage. Pictured here is an illustration from Bright Focus Foundation, which is a nonprofit organization that supports basic scientific investigations to better understand and find cures for Alzheimer's disease, age-related macular degeneration, and glaucoma. In the normal cross-section of the macula, there is a space called Bruch's membrane that is free of drusen, which is pictured in the dry form of AMD. In dry AMD, photoreceptors are degenerating and losing their normal shape, and this is also found in the wet form of AMD. Unique to wet AMD, new blood and blood vessels are seen abnormally making its way into the layers of the macula. The first natural product therapy that I would like to highlight are two specific carotenoids, lutein and zeaxanthin. Carotenoids are naturally occurring pigments found in plants, fungi, algae, and bacteria. Humans do not synthesize carotenoids, so they must be ingested in food or via supplementation. Lutein and zeaxanthin are traditionally used as antioxidants in the human body, but specifically for ocular health, these two carotenoids are concentrated in the macula. Macular pigment absorbs blue light, which are high-energy short-wavelength light, and this protects the retina from photochemical injury. These carotenoids also have local antioxidant properties with the ability to neutralize singlet oxygen and reactive oxygen species, protect against UV-induced peroxidation, and reduce the formation of lipofuscin and associated oxidative stress-induced damage. Study number 1 was a randomized, double-blind, placebo-controlled study that recruited 112 male and female patients over the age of 50 with early AMD from Beijing, China. The purpose of the study was to determine the effect of lutein-zeaxanthin supplementation on macular pigment optical density and retinal functions, and whether increasing macular pigment optical density might affect retinal sensitivities using two objective visual measurements with the microperimeter and multifocal electroretinogram. Subjects are randomly assigned to one of either four groups: 10 milligrams of lutein, 20 milligrams of lutein, 10 milligrams of lutein with 10 milligrams of zeaxanthin, or placebo daily for 2 years. Macular pigment optical density was quantified at baseline, 24 weeks, 48 weeks, and 2 years. Retinal sensitivities were measured by multifocal electroretinogram at baseline in 48 weeks, followed by microperimeter at 48 weeks and 2 years. No adverse events were observed or reported, and macular pigment optical density progressively increased after supplementation with lutein and zeaxanthin, while no significant change was observed in the placebo group. This study found that 2 years of lutein-zeaxanthin intervention resulted in a significant macular pigment optical density increase as well as functional retinal improvement. Study 2 was a randomized, double-blind, placebo-controlled, two-center investigation of the effects of solely lutein supplementation. There were a total of 72 male and female participants with AMD between 50 to 80 years old, which was completed in Manchester, United Kingdom, and Maastricht, Netherlands. The purpose of this study was to investigate the effect of daily supplementation with lutein capsules on macular pigment optical density and visual acuity in patients with early AMD. The subjects were randomly assigned to one of either two groups. The intervention group took 10 milligrams of lutein, and the placebo group took soybean oil capsules over the course of 1 year. Macular pigment optical density and visual acuity were measured at baseline and quarterly. Blood serum samples were also collected to monitor for compliance. Researchers found that lutein supplementation increases macular pigment optical density levels in early-stage AMD patients, and the visual acuity measurements indicated that the progress of the disease might be slowed down in some patients with augmented levels of macular pigmentation. No adverse side effects were reported. Study 3 was a major clinical trial conducted throughout the U.S. called the Age-Related Eye Disease Study 2, or AREDS-2. The purpose was to determine if adding lutein and zeaxanthin and/or omega-3 fatty acids to the original AREDS formulation would make it more effective and safer for reducing the risk of advanced AMD and cataract. Beta-carotene was substituted with lutein and zeaxanthin from the original AREDS formulation. AREDS-2 was a multi-center Phase 3 randomized placebo-controlled trial that included 4,203 male and female participants who were followed for 5 years. The mean age of the subjects was 74 years old, and all had intermediate or advanced AMD. The protocol included a placebo group, lutein and zeaxanthin group, DHA and EPA group, and a lutein, zeaxanthin, DHA, and EPA group. Progression to advanced AMD was established by the examination of retina photographs or treatment for advanced AMD. The researchers concluded that omega-3 fatty acids had no effect, and lutein and zeaxanthin together appeared to be a safe and effective alternative to beta-carotene. Lutein and zeaxanthin are safe, natural therapies, and there is ample research to support its efficacy in AMD. Mechanisms for its use are well established, and long-term effects have also been observed. The next natural product therapy for AMD is saffron. Saffron is a plant-derived spice that is mainly used in cooking for color and flavor. It's also used in herbal medicine as a nerve sedative, stress reliever, and antidepressant. Some of its underlying mechanisms on AMD include anti-inflammatory, antioxidant, and neuroprotective mediating effects. Study 1 evaluated the efficacy and safety of saffron supplementation in retinal function and AMD treatment using a placebo-controlled, double-blind, randomized controlled trial. This study was based in Iran and involved 60 male and female subjects over 65 years old with dry and wet AMD. The intervention group took 30 milligrams of saffron per day over 6 months. The wet AMD subjects also took eye injections in addition to the study protocol. Researchers used optical coherence tomography, electroretinography, fluorescent angiography, and visual acuity testing measures at baseline and 3 and 6 months after treatment. 6 months after treatment, no statistically significant decrease in optical coherence tomography results was observed between the groups with dry AMD. However, there was a statistically significant increase in electroretinography results between the groups at 3 months after treatment. Daily supplementation with 30 milligrams of saffron for 6 months may result in a midterm significant improvement in retinal function in patients with AMD. Study 2 aimed to assess the efficacy and safety of oral saffron in treating mild to moderate AMD using a randomized, double-blinded, placebo-controlled crossover trial of 100 adults over 50 years old in Australia. Participants were given 20 milligrams per day of oral saffron supplementation for 3 months or placebo for 3 months, followed by crossover for 3 months. Participants who were already consuming AREDS supplements were allowed to continue them. Primary outcomes included changes in best-corrected visual acuity and changes in multifocal electroretinogram response density and latency. Mean best-corrected visual acuity improved and mean pooled multifocal electroretinogram latency reduced on saffron compared to placebo. There were 10 cases of serious adverse events involving death, bowel cancer, and falls, among others, during saffron supplementation. Saffron supplementation modestly improved visual function in participants with AMD, including those using AREDS supplements. Study 3 evaluated the impact of saffron supplementation on visual function in patients with dry AMD using a placebo-controlled, randomized controlled trial design. This study was conducted in Iran and included 54 adults over 50 years old. The study protocol included a 50 milligram per day saffron intervention group and a placebo group during a 3-month period. Visual acuity, contrast sensitivity, and retinal thickness were measured at baseline and at the end of the study. Significant increases in visual acuity and contrast sensitivity were found in the intervention group. Short-term consumption of saffron may slow down the progression of disease and improve contrast sensitivity in AMD. After reviewing the studies for saffron's use in AMD, there are no direct adverse effects and no substantial long-term studies with ample sample sizes to justify saffron's use in slowing the progression of AMD. As far as my recommendations for lutein and zeaxanthin, there's strong research to support its use for AMD when used in the AREDS 2 formulation, as seen below. For saffron, however, its use in AMD is questionable. Vitamin D and goji berry are 2 natural therapies that are budding in research for AMD. A possible physiological role of vitamin D in the retina is supported by evidence that the vitamin D receptor and the enzymes involved in the metabolism of vitamin D are expressed in the retina. Vitamin D may reduce the risk or slow the development of neovascular AMD by
inhibiting angiogenesis or immune cell activation. Goji berries may increase serum zeaxanthin concentrations, macular pigment optical density, and visual function in patients with early AMD. More research is expected in these areas.
Here is a list of my references used for this presentation.